Good morning, everybody, and thank you, Dr. Krishnaveni, for giving me this opportunity to speak on a topic which can be a vexing clinical problem in our daily practice. Because when we speak of a pregnant patient with heart disease, a pregnant woman, I wouldn't call her a patient, a pregnant woman with heart disease, we are dealing with two lives. There are two lives at stake. Also at stake is the professional reputation of two physicians, one an obstetrician, the other is a cardiologist. So it's a high stakes game, and we need to tread really carefully when we deal with these situations. I would try to address the wide ranging topic of heart disease in pregnancy with a few illustrations of case examples that we have seen. This is a 26-year-old primary gravida who has come to the ER with palpitations and dizziness. And her EKG shows a tachycardia. It's a supraventricular tachycardia at a rate of 220 beats per minute. So what is the risks associated with this kind of arrhythmia in a pregnant individual? Obviously, at such a heart rate, there will be a decline in the cardiac output. A normal young adult would tolerate this for a period of time without any consequence. But a pregnant woman who is actually bearing another life in her womb will likely face certain unpleasant consequences of this kind of heart rate going on for a longer time than required. So there will be a decrease in cardiac output, which will obviously cause uteroplacental hypoperfusion, and there's a risk of preterm labor. And how do we manage this? We normally try vagal maneuvers in a good percentage of individuals by doing a good carotid sinus massage or other vagal maneuvers. We can actually terminate the tachycardia. If that fails, we can give intravenous adenosine, which is quite safe in all stages of pregnancy, and it will usually act within a few seconds, and the patient will be restored to sinus rhythm. If that doesn't work, we may have to use intravenous beta blockers, or in some rare instances, we may have to use intravenous diltiazem. And in extreme rare instances when nothing works, if the patient is hemodynamically unstable, we may have to cardiovert the patient. There are certain gender differences in arrhythmias between men and women. Women in terms of arrhythmias are generally more susceptible to cardiac arrhythmias because they have higher intrinsic heart rates, and there is a shorter sinus node recovery time that predisposes to a lot of atrial arrhythmias. The QT intervals in women are longer, and women are more likely to suffer from drug-induced torsades, which can be a fatal arrhythmia. Though overall, if you look at statistically, the likelihood of a woman having a sudden cardiac death is much lesser than a man. However, the incidence of torsades because of drugs is much higher among women. And if you look at the incidence of the common supraventricular tachycardias, the incidence is much higher in women. Pregnancy itself is considered as a pro-arrhythmic state. That's because of the altered hormonal state of the estrogens and the beta human chorionic gonadotropin. There's an increasing circulating blood volume, which is an increased cardiac output that causes a myocardial stretch, which causes a predisposition to cardiac arrhythmias. And there are increased circulating catecholamines in pregnancy. There's a higher sensitivity of the adrenergic receptors. All these create an environment that is conducive for arrhythmogenesis, and therefore pregnancy itself is considered a pro-arrhythmic condition. So people, women who never had arrhythmias that manifest for the first time during their pregnancy, and women who had arrhythmias in the past will often experience an exacerbation of their symptoms because of pregnancy. So quite often, thankfully, these arrhythmias are benign. They're in the form of ectopics. There may be in the form of isolated ventricular or supraventricular ectopics, or it could be some kind of an inappropriate sinus tachycardia. In these situations, often they are benign, and all we need to do is to reassure the individual that this would pose no increased risk either to the mother or to the fetus that the mother is carrying. In some situations, the symptoms are so severe and the arrhythmia is significant that we may have to use some drugs. And drugs are a double-edged sword in a pregnant woman, and there are very few drugs that are totally safe in pregnancy, and therefore we use the drugs only when absolutely necessary. Beta blockers and calcium blockers are generally considered safe, though they come under category C, but they're generally accepted to be safe during pregnancy for both the mother as well as the fetus, with some acceptable adverse effects that are expected from them. In some situations, the situation is so desperate that we may have to do an invasive procedure such as an electrophysiological procedure and do radiofrequency ablation of the arrhythmia circuit. And however, in our experience, as well as in the experience that has been reported in literature, electrophysiological studies and radiofrequency ablation under fluoroscopic guidance is safe, is relatively safe during pregnancy, especially if it is performed in the second trimester of pregnancy. Normally, there is a certain cutoff value of radiation exposure in terms of what is harmful for the fetus, and that is up to 10 millisieverts. This is the exposed radiation limit, and most of our procedures we do within 3 or 4 millisieverts. So we have a safe margin there in case it is required.